The immune system is responsible for coordinating complex responses against harmful agents, but some individuals may have aberrant immunological responses which lead to undesirable consequences for the host. These aberrant responses are the basis for clinical disorders of the immune system. My name is Hiroko Martin, and I am a fourth-year medical student. Thank you for tuning into this lecture on immunopathology. This lecture will emphasize immune disorders caused by imbalances in the immune response, particularly in hypersensitivity and immunodeficiency. The immune system is vital for host defense and, ultimately, survival. From a physiological point of view, the most important function of the immune system is to confer resistance to disease. The immune system recognizes and responds to foreign and dangerous substances by activating a network of complex processes. The ideal outcome of these processes is to completely eliminate the offending agent. The immune system is constantly defending against infection, but protection against pathogens is not its only function. The immune system also detects and actively defends against tumors, participates in the clearance of diseased, aging, and dead cells, and it is also responsible for initiating tissue repair after injury. A functional immune system is a vigilant mediator between the internal environment and the external environment. Its activities must be aimed at prioritizing health. An optimally functional immune response is therefore dependent on the balance between the integrity of the host's defenses and the ability of a harmful agent to resist or escape these defenses. The immune system is the most important factor in determining our ability to resist disease. Its effectiveness relies first and foremost on immunological tolerance, or the ability to discriminate between self and non-self. The integrity of the immune system relies on this tolerance, and strength is then dependent on the interplay between immune surveillance, or the monitoring processes of the immune system that serve to control and eliminate, in a broad sense, any foreign substances, cells, or tumor cells, the defense provided by the effector mechanisms of both branches of the immune system, and finally, the regulatory mechanisms designed to limit the damage caused by the immune response. A healthy immune system maintains a balance of responsiveness. A disordered immune system, however, is characterized by aberrant or undesirable function, especially due to imbalances in immunologic activity. On one end, if there is an exaggerated or inappropriate immune response, the immune reaction itself can lead to tissue injury and disease. This type of immune-induced injury is characteristic for hypersensitivity diseases, which also include autoimmune diseases. On the other hand, a defective immune system, as in immunodeficiency syndromes, can result in a suboptimal or even complete lack of an immune response. This will, not surprisingly, result in clinical states characterized by unusual, persistent, or frequent infections. For the sake of completeness, transplant rejection is also included here as a disorder of the immune system. In allogeneic transplantation, the source of the transplant material is from a genetically non-identical donor. Technically, the recognition of an allotransplant graft as being foreign to the host is an appropriate response by the immune system because of the mismatched MHC antigens. However, the process of rejection itself is an undesirable outcome, and it remains a major barrier to success in transplantation medicine. Nonetheless, moving forward, for the remainder of the talk, only the two extremes in immune function, hypersensitivity and immunodeficiency, will be further detailed. So let's start with the hypersensitivity reactions. Hypersensitivity refers to tissue injury and disease caused by pathological immune reactions. Several types of hypersensitivities are recognized, but the main immunologic principle underlying the dysregulation is inappropriate sensitization. Normally, when the immune system recognizes a threat, a specific immune response is mounted against that threat so that it can be efficiently eliminated. This process is known as sensitization because the immune system becomes sensitive to activation by that threat. However, in hypersensitivity reactions, sensitization may instead occur in response to a relatively harmless substance that has been misidentified as harmful. As a result, in a sensitized individual, Subsequent and repeated exposure to the harmless substance triggers the effector phase, in which the immune system responds with excessive and misdirected reactions. This is why these reactions are referred to as hypersensitivity. Hypersensitivity reactions are elicited by antigens. These antigens can be exogenous or endogenous. Common exogenous antigens include those found in the environment, drugs, and microbial organisms. Endogenous antigens, on the other hand, are self-antigens, and reactions directed towards self-antigens are referred to as autoimmunity. A state of autoimmunity and the clinically resulting disorders are autoimmune diseases. In other words, autoimmunity is basically a subset of hypersensitivity, and the basic pathophysiological mechanisms in autoimmune diseases are the same ones as those found in hypersensitivity diseases. In this sense, the term autoimmunity serves to specify and emphasize the source of the antigen, whereas hypersensitivity is a more general term. Just a quick note. From an etiologic standpoint, it is important to recognize that the mechanisms of tissue injury in hypersensitivity reactions are actually the same reactions as those used in the physiologic effector mechanisms of defense. However, because these responses are dysregulated, they will result in acute tissue injury and clinical disease in inappropriately sensitized individuals. In the 1960s, British immunologists Gell and Coombs divided hypersensitivity reactions into 4 types based on their underlying pathophysiological immune mechanisms. These reactions can be referred to as either numerically as type 1, type 2, type 3, and type 4 hypersensitivity, or they can be referred to by descriptors of their mechanism. We can also divide the hypersensitivities based on whether the effector phase of the response is transmitted by humoral mechanisms or by cellular mechanisms. Hypersensitivities types 1 through 3 rely on humoral mechanisms. They require active production of antibody by plasma cells, which are the terminally differentiated B cells. The difference between types 1 and types 2 and 3 is that type 1 hypersensitivity uses IgE antibodies, while types 2 and 3 use either IgG or IgM antibodies. Type 4 hypersensitivity differs from types 1 through 3 because it is dependent on cell-mediated immunity. Type 4 reactions are mediated by the interaction of T cells and macrophages. Another quick mention here. It is worth noting that while the Gell and Coombs classification scheme is convenient in explaining how immune responses can effect tissue damage, the damage in many immunologic diseases is actually a result of a combination of multiple hypersensitivity mechanisms. The first type of hypersensitivity is type 1 or intermediate hypersensitivity. These are reactions in which T helper type 2 or Th2 cells, IgE antibodies, and mast cells play a role. The damage-inducing effector phase is a rapid immunologic reaction induced by IgE antibodies coupled to mast cells in a previously sensitized individual. Within minutes of encountering an antigen, the sensitized mast cells release various mediators that cause tissue injury. Disorders in which this type of hypersensitivity is prominent are also called allergy, and the antigens that elicit allergic reactions are called allergens. These reactions may be localized or systemic, and various tissues may be affected. The quality of allergic reactions is variable between individuals. To be more specific, the clinical presentation of an allergic reaction in one person may be completely different from the presentation in another person, even for the same allergen. There is an association with inheritance of particular susceptibility genes and the propensity to develop allergies. This genetic predisposition is known as atopy, and genetically susceptible individuals are said to be atopic. Allergies are the most common clinical disorder of the immune system, according to the American Academy of Allergy, Asthma, and Immunology. Allergies may affect between 10 to 30% of the global population, and the prevalence of allergic disease has been rising worldwide since the 1950s. Common allergens include environmental allergens and food allergens. Some examples of environmental allergens might be pollen, dust mites, or animal dander from cats and dogs. Common food allergens could be, for example, nuts, milk, shellfish, but truthfully, allergens can be almost anything. Allergies can also be caused iatrogenically, when caused by medications or by administration of contrast media. The basic sequence of events precipitating immediate hypersensitivity is sensitization, followed by the effector phase. Allergies occur only in previously sensitized individuals upon reintroduction to the specific allergen. In fact, it is the reintroduction of the allergen that triggers the overreaction and subsequent tissue injury. In the sensitization phase, activation of effector lymphocytes, specifically Th2 cells, results in the production of sensitized mast cells. Sensitized mast cells are IgE-coated mast cells prepared for the next encounter with the allergen. This phase has no symptoms. If the allergen is re-encountered, binding of the allergen to the IgE-coated mast cells leads to degranulation of the mast cell, which discharges the mediators responsible for the clinical manifestations of the reaction. In some cases, the clinical manifestations of the effector reaction may consist of two distinct and well-defined phases: the immediate reaction, which occurs within minutes, and the late phase reaction, which may develop within several hours after exposure to an allergen. The immediate reaction is characterized by vasodilation, bronchospasm, and some other manifestations, while the late phase is characterized overall by inflammation. These phases differ in their manifestations because there is a shift in the types of mediators released by the activated mast cells over the time course of the reaction. Now let's dive a bit deeper into the immune mechanisms in the sequence of events leading up to the allergic reaction. As previously mentioned, the first set of events that must occur is sensitization to an allergen. This phase is initiated by Th2 cells. One of the hypotheses of allergy characterizes atopy as a state driven by a predominance in Th2 cell response. If we return to basic immunology, recall that Th2 cells belong to a subset of effector T lymphocytes known as helper T cells. Helper T cells, or Th cells, are a special subset of CD4 positive T cells that are instead distinguished by their cytokine profiles. These cytokine profiles reflect the physiologic functions of the helper T cells. In other words, the cytokine profile is a sort of repertoire that indicates what kind of microbe the helper T cell is best at helping to eradicate. So Th2 cells in particular are activated under physiologic conditions in helminth infections and promote eradication of these worms using IgE, mast cells, and eosinophils. The cytokine profile of these Th2 cells matches their function. The signature cytokines secreted by Th2 cells are IL-4, IL-5, and IL-13, which are all important in carrying out Th2 mechanisms. For now, the most important cytokine will be interleukin-4, since this one kicks off the sensitization by stimulating IgE production and activating Th2 cells. Now, let's go back to immediate hypersensitivity. In atopic individuals, for some reason, some harmless antigens, which we call allergens, are more likely to induce a strong Th2 response. It is precisely this activation of Th2 cells by the allergen that precedes the development of an allergy, because these Th2 cells then go on to stimulate the production of the final IgE mast cell complex that is implicated in causing injury in immediate hypersensitivity. So, the initial introduction of an allergen induces differentiation and subsequent activation of Th2 cells. In return, the Th2 cells will begin to secrete interleukin-4, which serves two functions. The first is to stimulate class switching in B cells, which results in the production of IgE antibodies specific for the allergen. The second function of interleukin-4 is production of additional Th2 cells, which will lead to even more interleukin-4 secretion and development of even more Th2 cells. This is a positive feedback loop. The positive feedback loop causes a large number of allergen-specific IgE antibodies to be produced in response to the massive Th2 activation. These IgE antibodies then go on to bind to specific Fc receptors on mast cells. In other words, these receptors are specific for the Fc portion of IgE only, so that binding of IgE to the receptor results in coating of the mast cell. This completes the sensitization process. Once the sensitization process is completed, the individual is officially allergic to the allergen for which the IgE antibody is specific for. The next step is waiting for reintroduction of the allergen to meet the new and improved sensitized mast cells in the effector phase. I'd like to take a moment here to refresh our memory on mast cells, since they play a central role in allergies, and also to talk a bit about basophils, which are a bit similar to mast cells. Mast cells are granulocytes present in all connective tissues. They have cytoplasmic granules containing various biologically active mediators, which are released on activation of the cell. There are various mechanisms that can stimulate mast cell activation, including cross-linking of the specific IgE receptors, complement components C5a and C3a, which are known as anaphylatoxins, opioid drugs, bee venom, and even physical stimuli like heat and cold. Basophils are similar to mast cells in many respects and may be considered in some way as their counterpart circulating in the blood. Basophils even have the same specific receptor for the Fc portion of IgE, and like mast cells, they can also be activated by cross-linking of that specific IgE receptor. They also store similar bioactive mediators in their granules, so basophils can theoretically also play a role in immediate hypersensitivity. So, returning back again to immediate hypersensitivity reactions. Activation of sensitized mast cells happens when an allergen binds 2 or more IgE antibodies on the mast cell. When this happens, the receptors holding the IgE antibodies are cross-linked, which leads to a couple of responses. The first and immediate response is degranulation, or the rapid release of primary mediators. And the second response, which takes a bit longer, is de novo synthesis, followed by subsequent secretion of secondary mediators. These mediators are responsible for the clinical features of the immediate reaction in allergies and also set into motion the events that lead to what is called the late phase reaction, if it occurs. The primary mediators are the preformed mediators stored in the mast cell granules. They are immediately released on activation of mast cells. The main categories of preformed mediators are vasoactive amines and enzymes. The most important vasoactive amine is histamine, which causes vasodilation in arterioles, stimulates transient contraction of smooth muscle, and, according to its location, increases glandular secretions in the nose, bronchi, or stomach. Excessive histamine release also causes intense itching. The enzymes found within the granules are proteases, which may cause damage to local tissues. The second mediators are newly synthesized mediators. Since they are not stored in mast cell granules, they are not released immediately with the primary mediators. It is precisely the activation of the mast cell that stimulates the production of these mediators, again, since they are not stored intracellularly. Secondary mediators include the eicosanoids, or arachidonic acid derivatives, and the cytokines. The eicosanoids are among the secondary mast cell mediators. They are 20-carbon lipid mediators formed from arachidonic acid, which itself is produced de novo. Arachidonic acid is synthesized from phospholipids in the plasma membrane in a reaction that is catalyzed by phospholipase A2. Activation of mast cells leads to activation of phospholipase A2. Arachidonic acid can then undergo further modification under one of 2 pathways, the lipoxygenase pathway and the cyclooxygenase pathway. The lipoxygenase pathway forms leukotrienes. The cyclooxygenase pathway generates prostaglandins and thromboxanes. Leukotrienes, prostaglandins, and thromboxanes are collectively referred to as the eicosanoids. Inhibition of this biosynthetic pathway is used clinically for therapeutic purposes. The important mast cell eicosanoids include leukotrienes B4, C4, and D4, and prostaglandin D2. These lipid molecules potentiate the initial response induced by the primary mediators. For example, leukotrienes C4 and D4 are supposed to be several thousand times more potent than histamine. The net effect of these eicosanoids in the hypersensitivity reaction is increased vascular permeability, bronchospasm, and increased mucus secretion. Cytokines produced by mast cells include tumor necrosis factor alpha, interleukin-1, interleukin-4, and chemokines. These are responsible for recruiting leukocytes, which induces local inflammation. Tumor necrosis factor alpha, interleukin-1, and chemokines recruit neutrophils and eosinophils, while interleukin-4 amplifies the Th2 response. Amplification of the Th2 response, in turn, leads to increased secretion of interleukin-5, which activates the eosinophils. The net result of cytokine activity is neutrophil and eosinophil-rich inflammation. Eosinophils are prominent components of many allergic reactions and are the main cause of tissue damage in these reactions. Upon activation, eosinophils release proteolytic enzymes that damage tissue. Whether an allergic reaction manifests locally or systemically depends to a large extent on the route of entry of the allergen. For example, inhaled allergens are more likely to activate mast cells in submucosal tissues of the bronchus. Similarly, ingested allergens are more likely to activate mast cells in the wall of the intestine. However, allergens which enter the systemic circulation, such as in the case of bee venom in some individuals, are more likely to activate mast cells systemically, producing systemic reactions. The prototypical clinical disorders in type 1 hypersensitivity are hay fever, food allergies, bronchial asthma, and anaphylaxis. Regarding the clinical presentation of type 1 hypersensitivities, local reactions may take the form of a localized cutaneous rash or blisters and urticaria, which is also known as hives. It can be also nasal and conjunctival discharge, in allergic rhinitis and allergic conjunctivitis, bronchoconstriction in bronchial asthma, or diarrhea in food allergy localized to the gastrointestinal tract. An example of the wheals formed in hives can be seen in the image on the right. On the other hand, anaphylaxis is a systemic reaction and is the most severe form of immediate hypersensitivity. It is potentially fatal. Anaphylactic shock is characterized by rapid onset of urticaria, bronchospasm, laryngeal edema, and shock. Massive systemic vasodilation causes widespread edema that affects the larynx and also causes a drop in blood pressure, which leads to distributive shock. Airway obstruction also occurs due to a combination of laryngeal edema and bronchoconstriction. The most common allergens triggering anaphylaxis are bee venom from bee stings and some food allergens like peanuts. Some drugs may also induce anaphylaxis. The first line of defense in anaphylactic shock is administration of epinephrine, which counters shock by inducing vasoconstriction, which increases the systemic vascular resistance and increases cardiac output by increasing the heart rate. Epinephrine also directly counteracts the bronchospasm and relieves the constriction by causing bronchodilation. Typically, individuals with a known risk for anaphylaxis carry around epinephrine autoinjectors, also known as EpiPens. Diagnosis of immediate hypersensitivity disorders is mainly based on symptoms and history. Other methods, like laboratory testing of blood samples and specific tests to determine specific allergens, may also be helpful and are used in indicated cases. Personal history of allergic reactions or family history of atopy are strong predictors of type 1 hypersensitivity disorders. Serology can be used to determine specific IgE antibodies. A complete blood count with white cell differential may show peripheral eosinophilia. However, this result in itself is not considered diagnostic, since eosinophilia can be caused by conditions other than allergy. Specific allergen tests, like intradermal allergy tests and skin prick tests, can also be used to confirm many types of common allergies. Provocation tests, such as oral challenge tests, might be used to determine food allergies, but these tests must be done with supervision. Treatment of allergies is aimed at inhibiting mast cell degranulation, antagonizing the effects of mast cell mediators, and reducing inflammation. The most important preventive measure is allergen avoidance, if avoidance of the allergen can be reasonably done. Otherwise, therapy of allergies include antihistamines to directly counteract mast cell degranulation, agents that relax bronchial smooth muscle in asthma, epinephrine in anaphylaxis, and topical or systemic corticosteroids, which function to inhibit phospholipase A2 and prevent formation of arachidonic acid and, of course, its downstream mediators, the eicosanoids. In selected cases, some patients may benefit from desensitization therapy, also known as allergen-specific immunotherapy. Desensitization is based on repeated administration of small doses of allergens by a series of injections to desensitize the immune response and generate tolerance to the allergen. Next up are the type 2 and type 3 hypersensitivities. Unlike type 1, which uses IgE antibodies, both types 2 and 3 use IgG or IgM antibodies. IgG and IgM antibodies may cause disease either through antigen-antibody interactions that directly damage or influence cellular targets, or through inflammation triggered by inappropriate deposition of immune complexes in tissues. In type 2, or antibody-mediated hypersensitivity reactions, IgG or IgM antibodies bind to antigens present either on cell surfaces or within tissues. These antigens are integral components of the cell or tissue. In these reactions, the antigen-antibody interaction either locally triggers damage or it interferes with the normal function of a tissue or cell. Because these reactions are formed at specific sites, these reactions are usually specific for a particular tissue. The source of the antigens may be exogenous or endogenous self-antigens. As a result, this type of hypersensitivity is recognized as an extremely common immunopathological mechanism present in several autoimmune diseases. The autoantibodies are going to be the antibodies directed against self-antigens. The first step in all antibody-mediated reactions is the binding of antibody to an antigen, which leads to further effects. The sequence of the events that occur after the first step is variable and depends on whether the net result to the antibody target is damage or the induction of a functional disturbance. Damage in type 2 hypersensitivity reactions is the result of leukocyte activity, mainly neutrophils and macrophages, in response to the binding of an antibody to an antigen. The end result of the leukocyte activity is either cytolysis or inflammation. Activation of these phagocytes is either Fc receptor mediated or complement mediated. In other words, the activation of leukocytes is either direct as the result of antibody activity or indirectly as the result of complement activation following antibody activity. Therefore, the major effectors of damage in type 2 hypersensitivity are antibodies, complement system, and the leukocytes. The most well-characterized immune mechanisms here are opsonization and phagocytosis, antibody-dependent cellular cytotoxicity, or ADCC, and inflammation. Phagocytosis is the main mechanism behind destruction of cellular targets in antibody-mediated hypersensitivity. In this type of reaction, antibodies bind to a cell membrane antigen on a target cell, which labels the cell as a target for phagocytosis. The reactions which follow the initial antibody binding may either be completed by complement or Fc receptors. Complement-mediated phagocytosis is initiated by either IgG or IgM, which are known as complement-fixing antibodies. They are referred to as complement-fixing antibodies because they are able to activate complement when reacting with an antigen. So, the reaction between IgG or IgM antibody with antigen activates the classical complement pathway, which generates complement mediators, mainly C3b and C4b. C3b and C4b then interact with the target cell surface in such a manner that leads to coating of the target cell by these complement components. This coating of the cell with C3b or C4b components is referred to as opsonization. A mediator which opsonizes the target is called an opsonin. Opsonization marks a target for destruction by phagocytes and also facilitates phagocytosis. In the Fc receptor-mediated reaction, IgG, but not IgM, can serve as an opsonin instead of complement components. When IgG acts as an opsonin by coating the target cell, activation of the complement system is not necessary. The reason that IgG, but not IgM, can serve as an opsonin is because phagocytes have special receptors for the Fc portion of IgG antibody, but not for IgM antibody. Phagocytes also have special receptors for C3b. So the final common steps shared between complement-mediated and Fc receptor-mediated reactions is that once the phagocytes reach the opsonized target, they are activated by engaging either their C3b receptors or the Fc receptors, or both, of course, and then they proceed to destroy the target by phagocytosis. Another damage-inducing mechanism in antibody-mediated hypersensitivity is inflammation. Inflammation, similar to phagocytosis, can also be complement-mediated or Fc receptor-mediated. Inflammation is the main mechanism causing tissue injury. When antibodies against tissue antigens deposit in fixed tissues, the presence of immune complexes activates complement. The activation of complement generates complement byproducts C3b and the anaphylatoxins C3a and C5a. C3a and C5a increase vascular permeability and also act as chemotactic agents for the leukocytes, mainly neutrophils and macrophages. Once the leukocytes reach the target site, they are activated by engaging their C3b and Fc receptors. This activation results in the production and release of reactive oxygen species and lysosomal enzymes that directly damage the surrounding tissues. The final mechanism thought to participate in antibody-mediated hypersensitivity is antibody-dependent cellular cytotoxicity, or ADCC. However, its significance in antibody-mediated hypersensitivity is uncertain. ADCC is destruction of cells that are coated with IgG cells, mainly by NK cells. However, macrophages may also be an effector. These cells bind to the target using their IgG-specific Fc receptors, which results in cytolysis without phagocytosis. Examples of non-autoimmune diseases resulting from damage induced by type 2 hypersensitivity include transfusion reactions and hemolytic disease of the newborn, also known as erythroblastosis fetalis. In both of these examples, disease is mediated by direct destruction of red blood cells due to the presence of target antigens on the erythrocyte surface. Transfusion reactions occur following transfusion of an incompatible blood type in an individual with preformed antibodies against ABO antigens, or Rh reactions. Hemolytic disease of the newborn can occur when an Rh-negative mother with an anti-Rh IgG antibody is pregnant with an Rh-positive child. The anti-Rh IgG is able to cross the placenta and leads to the destruction of the fetal red blood cells. A subtype of antibody-mediated hypersensitivity reactions is not associated with cellular tissue injury, but instead is associated with functional impairment. In these cases, antibodies directed against cell surface receptors leads to cellular dysfunction or impairment of the receptors rather than damage. The result of this functional impairment may be activation of the receptor or blockage of the receptor. This mechanism is seen in autoimmune conditions like Graves' disease and myasthenia gravis. In Graves' disease, antibodies against the thyroid-stimulating hormone receptor on the thyroid epithelial cells leads to activation of the receptor. The result is that the receptor is activated even in the absence of thyroid-stimulating hormone, which manifests clinically as hyperthyroidism. Conversely, in myasthenia gravis, antibodies against the nicotinic acetylcholine receptors at the neuromuscular junction bind to and block the receptor. Unlike in Graves' disease, these autoantibodies do not activate the receptor. Instead, by binding to the receptor, they prevent binding of acetylcholine, which effectively decreases the number of functional receptors. As a result, a typical manifestation of myasthenia gravis is muscle weakness. Moving on to type 3, or immune complex-mediated hypersensitivity, this hypersensitivity is characterized by the formation of antigen-antibody immune complexes. Damage in these reactions is usually the result of inflammation induced by the immune complexes because they are deposited and accumulate in inappropriate locations. Once again, the antigens may be exogenous or endogenous. Immune complex-mediated hypersensitivity is yet another recognized mechanism commonly found in autoimmune diseases. So, These reactions are usually systemic, since the immune complexes are usually formed from circulating antigens. The onset of symptoms usually occurs around 10 days after exposure to the antigen. The sequence in the pathogenesis of systemic disease is formation of immune complexes, followed by deposition of the immune complexes, and finally, the resulting inflammation and tissue injury elicited by the immune complex. A circulating antigen triggers an immune response that leads to the complexing of an antigen to antibody. The resulting complex has a tendency to deposit in blood vessels, especially in kidneys. An acute inflammatory reaction is induced after the complexes have been deposited in tissues. During this period, the patient may begin to experience some nonspecific flu-like symptoms like fever, joint pain, and so on. If the source of the antigens is the result of a single antigenic overload, the immune complexes are eventually degraded, and the condition is therefore transient and limited to the time that it takes for the catabolism of these immune complexes. However, if the source of the antigens is chronic, the resulting inflammation from these complexes will also exhibit chronicity. The immune response is mediated by complement-fixing antibodies in a mechanism similar to the one seen in antibody-mediated hypersensitivity. Common clinical manifestations associated with systemic immune complex deposition are based on the location of the inflammation following immune complex deposition. Immune complexes deposited in blood vessels cause vasculitis, complexes deposited in the renal glomeruli cause glomerulonephritis, complexes deposited in joints cause arthritis, and so on and so forth. An example of immunohistochemistry demonstrating immune complex-mediated glomerulonephritis can be seen on the image to the right. Local disease is much less common than systemic disease. This can result from the formation of insoluble immune complexes at the site where the antigen has been planted. Because the complexes are insoluble, they cannot be efficiently cleared by phagocytosis. As a result, the complexes remain and deposit locally. This can be seen, for example, in extrinsic alveolitis, in which the offending antigen is inhaled and the immune complexes deposit locally in the respiratory tract, causing respiratory symptoms. The last of the hypersensitivities is type 4 or T-cell mediated hypersensitivity. These reactions are effected by sensitized T cells, particularly CD4 positive helper T cells, and to a lesser extent, CD8 positive cytotoxic T cells. Out of the 4 types of described hypersensitivities, type 4 is the only one which is caused by cell-mediated immunity. These hypersensitivities involve T-cell antigen interactions that induce T-cell activation and secretion of cytokines, which in turn induces either inflammation or direct cytotoxicity. The antigens may be endogenous or exogenous. However, this type of hypersensitivity is strongly associated with damage that is primarily due to an overaggressive immune response rather than due to the intrinsic pathogenicity of the antigen itself. Substances which are able to activate T-cell responses include low molecular weight haptens, superantigens from viruses and bacteria, and some self-antigens. The immune mechanisms can be described according to whether the mediator is CD4 positive helper T cells or CD8 positive cytotoxic T cells. The majority of T-cell mediated hypersensitivity reactions are mediated by Th1 cells. The prototypical reaction mediated by CD4 positive T cells is the delayed type hypersensitivity reaction. The reaction is referred to as delayed because it takes somewhere between 24 and 48 hours to develop. This time period actually corresponds to the amount of time needed for sensitization of the effector T lymphocytes. CD4 positive T cells contribute to organ-specific diseases as the result of local inflammation and macrophage activation. Sensitized Th1 cells are sources of interferon gamma, which activates macrophages, and Th17 cells are responsible for recruiting neutrophils and other leukocytes. Macrophages act as the antigen-presenting cells in delayed type hypersensitivity. The sensitization process begins when they present antigen to the Th1 cell. They complex antigen to HLA class II molecules to present the CD4 positive Th1 cell the antigen. The Th1 cell is then activated upon co-stimulation between the presented antigen HLA class II complex and its T cell receptor, resulting in the release of cytokines such as interleukin-2. These cytokines then stimulate the proliferation of antigen-specific CD4 positive memory T cells. Upon subsequent contact with the antigen, CD4 positive memory T cells proliferate and secrete inflammatory cytokines, mainly interferon gamma, which recruit and stimulate macrophages to destroy the offending agent. When the offending agent is destroyed, the immune response is terminated. If for some reason macrophages are unable to eliminate the offending antigen, the inflammatory response persists. In this case, a granulomatous reaction results from the persistent immune activation and resulting excessive macrophage response. In this condition, because the macrophages fail to eliminate the antigen, the immune system tries to compensate for the failed response by recruiting even more macrophages. More T cells are also simultaneously activated, and these T cells end up stimulating recruitment and activation of even more macrophages, and so this collection of phagocytes begins to build up around the offending agent as an attempt to wall off and contain the pathogen. This focus is called a granuloma. This pattern of inflammation is seen in diseases such as tuberculosis, leprosy, and sarcoidosis. Again, these are reactions that manifest not necessarily due to the pathogenicity of the causative agent, but rather because of excessive response on behalf of the immune system. The Ppd test, also known as the tuberculin test, is the prototypical example of the delayed type hypersensitivity reaction. This test is used as an indicator of T cell response to mycobacteria. Ppd, which stands for purified protein derivative, is an antigenic extract from Mycobacterium tuberculosis. The protein is injected into the skin and the response is observed after 1 to 2 days. A positive response manifests clinically as an indurated and erythematous lesion at the site of the Ppd injection. Contact dermatitis is a very common example of tissue injury resulting from a delayed type hypersensitivity reaction. It may be caused by chemicals referred to as haptens. Haptens are very small and therefore are not antigenic on their own. They are only able to elicit a response when complexed with carrier protein. However, due to their small size, they are easily able to penetrate the skin and cause local dermal irritation. Therefore, they are a frequent cause of environmentally induced T-cell mediated hypersensitivity. This condition is known as contact dermatitis. Some common haptens associated with contact dermatitis include the metal nickel, found in jewelry for example, and the chemical urushiol found in poison ivy. The typical clinical manifestation of this reaction is a skin rash with redness, blistering, pain, itching, and some others. Some therapeutic drugs may also act as haptens. CD8 positive cytotoxic T-cell mediated reactions are thought to mediate some autoimmune diseases. They are known to play a major role in graft rejection. Cytotoxic T cells specific for antigens on host cells may directly kill these cells by lysis. Cytotoxic T cells directly kill cellular targets by producing various cytotoxins. A pore is formed in the plasma membrane of the target cell using perforins. Then granzymes are injected into the cytoplasm of the target cell. The granzymes are proteases, so upon entering the cell they activate caspases, which leads to apoptosis of the target cell. CD8 positive T cells also produce inflammatory cytokines like interferon gamma, but they are not considered a major source of cytokines in immune reactions. At the beginning of this lecture, the immunopathological states were grouped according to the nature of the immune responsiveness. We have discussed dysregulated immune responses, so now let us turn our attention to hypoactivity and inadequacy of the immune system. Immunodeficiency refers to a state in which the immune response is defective. The immune response may be compromised or even completely absent. Unsurprisingly, immunodeficiency manifests clinically as an increased susceptibility to infections or a protracted course with latent or persistent infections. Immunodeficiency may be classified as congenital or acquired according to the underlying basis of the defect. Congenital immunodeficiency, also referred to as primary immunodeficiency, results from genetic abnormalities in one or more components of the immune system. In acquired immunodeficiency, also called secondary immunodeficiency, the immune function was previously normal, but becomes defective as a result of alterations to components of the immune system. Unlike in congenital immunodeficiency, acquired immunodeficiency does not have a genetic background and has a wider etiological spectrum. Acquired immunocompromisation can be the result of infectious causes, nutritional deficits, or it may even be iatrogenic due to the use of immunosuppressants, for example. Let's take a look at congenital immunodeficiency. Again, these are compromised immune states caused by genetic defects that impair the physiologic function of the immune system. The most common feature of these immunodeficiencies is infectious complications. The nature of the infectious consequences is closely correlated to whichever immune component is defective. In theory, any component from any division of the immune system can be affected, but some components are more commonly affected than others. If we group the causes of the congenital immunodeficiency according to their defective immune component, we can distinguish between two major groups: defects affecting lymphocytes, which include conditions that impair B or T cell function by blocking their maturation or activation, and we can also distinguish defects affecting the innate immunity, which usually pertain to impaired function of phagocytes and the complement system. However, primary immunodeficiency can also just be a single component of disease in more complex syndromes. In defects affecting lymphocytes, the manifestations of the defects in lymphocyte function depend mainly on whether B lymphocytes or T lymphocytes are affected. However, it's worth mentioning that these distinctions are not really clear-cut because of the codependence and interplay between the humoral and cell-mediated arms of adaptive immunity. In B-cell deficiencies, the defect affecting B-cell function may be found anywhere along the B-cell lineage. For example, the defect may affect the maturation of B lymphocytes so that pre-B cells can't differentiate into B cells. On the other hand, in some cases, the maturation process may be just fine, so that mature B cells are formed, but the defect instead affects antibody production in the mature B lymphocytes. However, regardless of the stage in which the B cells are affected, any defect in B cells will also affect immunoglobulin activity, since their primary function is to produce antibodies. As a result, B-cell deficiencies are generally characterized by an increased susceptibility to infection by encapsulated bacteria. Physiologically, antibodies are important mediators in neutralizing capsular antigens found on encapsulated bacteria such as Streptococcus pneumoniae and Haemophilus influenzae. Subsequent infection by encapsulated bacteria will then induce inflammatory responses that are rich in polymorphonuclear leukocytes like neutrophils, giving rise to pus. The result is that the individuals with B-cell deficiencies are more prone to pyogenic bacterial infections. Antibodies are also one of the mechanisms of immune responses to the viruses. They are able to neutralize virions after recognizing envelope antigens, which then prevents binding and subsequent entry into host cells. Because of this, individuals with B-cell deficiencies may also theoretically exhibit an increased propensity to viral infections. This is especially true if other major components of the immune response to viruses, like T cells and NK cells, are also affected. Infections in these individuals have a predilection for mucosal organs. The respiratory and digestive tracts are predominantly affected because secreted antibodies are especially important as the first line of defense in mucous membranes. Individuals may suffer from recurrent otitis media, bronchitis, sinusitis, pneumonia, and diarrhea. Another feature of B-cell deficiency is that the clinical manifestation can begin as early as 6 months. Remember that maternal antibodies protect the newborn through passive immunization, but this protection begins to wane fairly early on. The infant does not begin to make its own antibodies until around 6 months, which explains why clinical manifestations of B-cell defects can theoretically be seen within the first year of life. The first condition that we'll discuss affecting B lymphocytes is X-linked or Bruton's agammaglobulinemia. This is caused by a disruption in B-cell maturation. This disease is caused by mutations in the gene coding for Bruton tyrosine kinase, or BTK, resulting in its loss of function. BTK is an essential kinase for B-cell maturation. So, pre-B cells in bone marrow are unable to differentiate into mature B cells, so this syndrome is characterized by a marked decrease or complete absence of both mature B cells and immunoglobulins of all isotypes circulating in the serum. The BTK gene is found on the X chromosome, therefore this disease exhibits classic gonosomal inheritance. Males inheriting the mutation will always be affected, while females are carriers when the mutation is present only on one chromosome. The disease is said to affect only males because homozygous females are virtually unheard of. Patients typically present with recurrent pyogenic infections of the respiratory tract and digestive tract disorders due to gastrointestinal infection, starting from as early as 6 months of age. However, since this syndrome only affects B cells, their reactivity to viral infections is usually apparently normal, since the other components of the immune system are not affected. Dysgammaglobulinemia is a disorder characterized by abnormal levels of a specific class of immunoglobulins as a result of genetic defects affecting the production of immunoglobulin isotypes. The defect usually results in deficiency of a specific immunoglobulin class and therefore can be distinguished from hypogammaglobulinemia, which is a disorder characterized by reduction in all classes of immunoglobulins. The most common deficiency is likely IgA deficiency, which is thought to affect 1 in 700 individuals. IgA deficiency is associated with failure of IgM-bearing B cells to terminally differentiate into IgA-secreting plasma cells. Therefore, mucosal protection is diminished or lost due to the lack of secreted IgA from IgA-secreting plasma cells, but otherwise, the number of IgA-bearing B cells is normal. This may result in mild or no clinical disease. An interesting clinical note is the possibility of increased levels of anti-IgA antibodies in these individuals. If the anti-IgA antibody is of the IgE class, there is a risk of severe anaphylaxis if blood products like blood transfusion or immunoglobulin derivatives are administered. T-cell deficiencies are generally characterized by increased susceptibility to infection by intracellular pathogens and eukaryotic pathogens. Infections are typically viral, mycobacterial, fungal, and protozoal. As a result of the frequently complicated course of viral infection, T-cell deficiencies are also associated with increased risk of virus-associated malignancies, such as EBV-associated lymphomas. T-cell defects almost always lead to impaired antibody synthesis due to the importance of T cells in B-cell activation and immunoglobulin production. The most well-known congenital immunodeficiency affecting T cells is Digeorge syndrome, also known as 22q11.2 deletion syndrome. Digeorge syndrome is characterized by thymic hypoplasia or aplasia as the result of a defect during embryological development of the 3rd and 4th pharyngeal pouches, which are formed around the 12th week of gestation. The 3rd and 4th pharyngeal pouches contribute to the parathyroid gland and thymus. Therefore, this syndrome is associated with hypoparathyroidism in addition to the T-cell deficiency. The syndrome is typically due to deletion of genes from the long arm of chromosome 22. The poorly developed thymic tissue or completely absent thymus prevents adequate T-cell maturation. Other common clinical manifestations of Digeorge syndrome include a characteristic phatsias, cleft palate, seizures and tetany as the result of hypocalcemia due to the hypoparathyroidism, and cardiovascular defects. Severe combined immunodeficiency, or SCID, is a rare congenital immunodeficiency syndrome characterized by severe immunodeficiency. Unlike the previously mentioned disorders, which were manifestations of defects in either B cells or T cells, SCID is caused by defects in both B lymphocytes and T lymphocytes, as both humoral and cell-mediated immune responses are affected. Children affected by SCID are extremely susceptible to severe and complicated infections by a wide range of pathogens. They also have a very short lifespan. Without hematopoietic stem cell transplantation, death occurs within the first year. Several different genetic abnormalities are associated with SCID. The most common form of SCID is X-linked. This accounts for approximately 50% of cases, and of course, due to its inheritance, is much more common in boys than in girls. X-linked SCID is associated with mutations in cytokine receptors. These mutations affect multiple cytokine receptors, but have a particularly profound effect on T-cell precursors, which are oligopotent stem cells. As a result of defective receptor signaling in the lymphocyte precursors, the earliest stages of lymphocyte development are disturbed, especially in T cells. So T cells are deficient, and the thymus is abnormally small at birth, most likely due to the impairment in formation of mature T cells. B cells may actually be normal in number, but due to the lack of T cells, immunoglobulin production is impaired because helper T cell mediated activation and class switching in B cells cannot occur. The remaining forms of SCID are all autosomal recessive disorders. Immunodeficiency, as mentioned previously, can also occur as a minor component of other inherited systemic disorders. The major manifestations are non-immunologic. The two prototypical examples of such diseases are Wiskott-Aldrich syndrome and Ataxia Tylenotasia. Wiskott-Aldrich syndrome is another X-linked disease mainly occurring in children. It is characterized by eczema, thrombocytopenia, and immunodeficiency. The underlying defect in this syndrome is a mutation in a gene encoding proteins that are thought to link membrane receptors, such as antigen receptors, to the cytoskeleton. It is thought that this protein is involved in cytoskeleton-dependent responses like cell migration and signal transduction in lymphocytes, leukocytes, and platelets. And so because of the loss of function of this protein, these cells don't develop normally and fail to migrate normally, among other specific functions of these cells. The immunologic component is associated with defective T cell maturation and poor B cell function. In addition to severe recurring infections, affected children are also prone to developing B cell lymphomas. Ataxia Tylenotasia is an autosomal recessive disorder characterized by ataxia or gait abnormalities, telangiectasia or vascular malformations, and immunodeficiency. This disease is caused by mutations in a gene encoding a protein that is involved in DNA repair. Therefore, this defective protein causes abnormal DNA repair, which results in defective lymphocyte maturation. This can affect both B cells and T cells. Other clinical manifestations of this particular disorder include neurologic deficits and increased incidence of tumors. Congenital immunodeficiency disorders can also affect the defense mechanisms of innate immunity. Typically, the function of leukocytes or complement are affected. Chronic granulomatous disease is characterized by defective production of reactive oxygen intermediates in phagocytes. These reactive oxygen species are found within the lysosomes of neutrophils and macrophages and are absolutely necessary to kill phagocyte host microbes. The genetic defect behind chronic granulomatous disease is in the genes encoding the enzyme phagocyte oxidase, also known as NADPH oxidase in phagocytes. This enzyme is responsible for catalyzing the production of the superoxide free radical in a reaction known as oxidative burst. The phagocytes are unable to phagocytose properly as a result of the defect, which leads to the formation of granulomas, hence the name of the disease. Common clinical manifestations of this condition include pneumonia, abscesses of the skin, liver, and lungs, and osteomyelitis. Affected individuals are especially susceptible to catalase-positive microbes such as Staphylococcus aureus, E. coli, and Candida species. Catalase-negative microbes, on the other hand, are usually eliminated efficiently. Resistance to infection by these catalase-negative microbes is thought to be possible by somehow stealing hydrogen peroxide produced by the metabolism of these microbes as an alternative mechanism to form reactive oxygen intermediates. Hydrogen peroxide is able to spontaneously form superoxide, and so this basically allows the host to bypass the NADPH oxidase defect. So then, This takes us back to the catalase-positive organisms. The catalase enzyme catalyzes the reduction of hydrogen peroxide to water and oxygen. Since it is thought that the immune system is able to steal microbially produced hydrogen peroxide, this explains why the catalase-positive organisms are especially problematic in this condition. Catalase likely renders this hydrogen peroxide burrowing mechanism useless, and therefore triggers the subsequent formation of granulomas and abscesses. Deficiencies have been described for almost every complement protein. Deficiency of complement components C1 through C4 increase susceptibility to autoimmune disorders and bacterial infections. Deficiency in the terminal components of complement C5 through C9 increase susceptibility to recurrent infection by Neisseria bacteria. The most common deficiency is deficiency of C2, which is an early component of the classical pathway. C2 deficiency is associated with increased bacterial infections. However, many patients may have no clinical manifestations, likely because the alternate complement pathway is able to compensate for the defective classical pathway. C2 deficiency is also associated with an increased susceptibility to a systemic lupus erythematosus-like autoimmune disease, which is thought to be due to inefficient clearance of immune complexes. C3 deficiency increases susceptibility to serious and recurrent pyogenic infections, since this component is necessary for both classical and alternative complement pathways. There is also increased susceptibility to immune complex-mediated glomerulonephritis, as in type 3 hypersensitivity reactions. Deficiencies of complement regulatory proteins are associated with manifestations of excessive complement activation. Deficiency of C1 inhibitor is the most common deficient component related to the complement system. It is even more common than the C2 deficiency. It causes hereditary angioedema. Lack of this regulatory protein leads to uncontrolled and excessive activation of complement after stressful stimuli. Recruitment of the anaphylatoxins C3A and C5A triggers degranulation of mast cells and basophils, which then causes severe edema. When considering the possibility of a primary immunodeficiency disorder, there are features that can serve as suspicion markers. Primary immunodeficiency should definitely be strongly suspected if there is a family history of congenital immunodeficiency combined with failure to thrive or a suspicious infectious history. The acronym SPIR can be used to remember the features of infections suspicious for immunodeficiency. The S stands for severe, because these infections often require IV antibiotics and hospital admission. P is for persistent, because the infections are often difficult to treat with standard regimens. U is for unusual, because they are caused by opportunistic pathogens. And R is for recurrent, because these individuals frequently have repeated infection at the same site or with the same organism. Early onset autoimmune diseases and malignancy are also suspicious for primary immunodeficiency. Therapy of primary immunodeficiencies is dependent on the nature of the disease. As mentioned previously, SCID is fatal within the first year unless the patient's immune system is reconstituted through treatments like hematopoietic stem cell or bone marrow transplantation. Successful gene therapy has been reported in X-linked SCID, but this form of therapy is reserved for select cases. Bone marrow transplantation is also an indication in Wiskott-Aldrich syndrome. In B-cell defects associated with agammaglobulinemia or severe hypogammaglobulinemia, pooled immunoglobulins can be given intravenously as a method of passive immunization. This prophylactic therapy is used to compensate decreased antibody production and subsequently diminish infections. And of course, antibiotics are needed in all patients with primary immunodeficiencies. These can be given either prophylactically or therapeutically. Last but not least, let's move on to the acquired or secondary immunodeficiency syndromes. In simple terms, acquired immunodeficiency is a compromised immune response due to some other underlying cause affecting the immune system, rather than as a result of a defective immune system at birth. This type of immunodeficiency has a very wide etiological spectrum that includes infections, extremes of age, metabolic disturbances, drugs, radio and chemotherapy, immunosuppression, and tumors. These primary states can cause acquired immunodeficiency through mechanisms leading, for example, to defective lymphocyte maturation or depletion of lymphocytes, functional impairment of lymphocytes, or decreased immunoglobulin synthesis, among others. The normal aging process is also associated with a depressed immune response. By far, the most well-known and most common secondary immunodeficiency is AIDS. Acquired immunodeficiency syndrome, or AIDS, is caused by human immunodeficiency virus, or HIV. HIV is a retrovirus whose main target is the CD4 positive helper T lymphocyte, leading to the progressive destruction and depletion of these cells. There are two types of HIV, HIV type 1 and HIV type 2. The majority of human infections are caused by HIV type 1. The HIV life cycle begins with infection of CD4 positive cells. A DNA copy of the viral RNA is then produced and subsequently incorporated into the host genome. This is followed by expression of the viral genes and finally assembly of the viral particles. These particles are infectious and exit the host cell to infect other cells. The HIV virion is enveloped and contains two RNA strands within its protein core. The lipid envelope is derived from infected host cells, but it is coated with viral proteins. The viral RNA encodes structural proteins, various enzymes including reverse transcriptase, and proteins that regulate the transcription of viral genes and the viral life cycle. Prepackaged enzymes found within the protein core include reverse transcriptase, integrase, and proteases. The major envelope glycoprotein of an HIV virion is GP120, which has affinity for CD4 molecules found on the surface of immune cells like the CD4 positive helper T cells. In order to enter the host cell, this viral GP120 binds simultaneously to CD4 and a co-receptor, which is either CXCR4 or CCR5 for entry. CXCR4 and CCR5 are chemokine receptors. The major targets are CD4 positive helper T cells. However, by virtue of GP120, HIV is able to infect any CD4 positive cell. Cells like macrophages, dendritic cells, and microglial cells like astrocytes in the central nervous system have much lower numbers of CD4 molecules on their membrane surface, but can also be infected. This potential infectious mechanism of other CD4 positive cells is important for a couple of reasons. For one, it is thought that the infection of non-T helper cells, like macrophages, may act as reservoirs for HIV. It is also thought that this type of infection may explain CNS manifestations in the progression of AIDS. Macrophages might serve as a route of entry into the central nervous system, or alternatively, HIV particles might be able to directly infect microglial cells in the central nervous system. So, after the viral particle binds to CD4 and its co-receptor, the viral envelope fuses with the host cell membrane, and the viral contents are then injected into the cytoplasm. Prepackaged reverse transcriptase from the virion then synthesizes a DNA version of the viral RNA in the cytoplasm, and then another enzyme called integrase integrates the DNA copy into the host genome. This integrated viral DNA is called a provirus. At this point, if some stimulus activates transcription in the host cell, for example, a microbial infection, the host cell may also transcribe the proviral DNA in addition to its own genes. Transcription of the provirus produces viral RNAs, which is then used to produce new viral components. Eventually, this entire process results in the creation of new viral particles capable of infecting more cells, which renews the viral cycle. The newly synthesized virions can exit the cell either through surface bedding or lysis. If the cells exit through lysis, the host cell is killed. The animation to the right depicts the exit of HIV virions through surface bedding, followed by infection of another cell. The status of the HIV infection can be described as active or latent. An infection is said to be active when all of the steps of the HIV life cycle are fully completed. In other words, active infection always leads to the creation of new viral particles. However, if the HIV provirus is silent and is not being transcribed, the infection is said to be latent. The provirus can stay hidden in a latent state within infected cells for months to years. An interesting clinical note is that some individuals are resistant to HIV infection because of a mutated CCR5 receptor. Homozygotes for this defective receptor are relatively resistant to infection and development of AIDS, while heterozygotes are not protected from AIDS, but instead exhibit delayed onset of the disease after infection. This animation summarizes the HIV life cycle: binding and fusion, followed by reverse transcription and integration, replication, assembly, and the exit of new virions by budding. AIDS is a progressive disease that develops over many years. Latent HIV is activated and subsequently destroys host immune cells, progressing to immune deficiencies and eventually clinical AIDS. There are several routes of transmission for HIV. HIV can be acquired through sexual intercourse, parenterally by sharing contaminated needles in intravenous drug usage, or vertically from mother to child. Previously, transfusion of blood and blood products was a more significant route of parenteral acquisition of HIV. However, screening methods to detect HIV in blood donations have significantly decreased infections from this route. Vertical transfer of HIV from mother to child may occur by transplacental transfer, during delivery, or by breastfeeding. HIV virus is found in all bodily fluids: blood, semen, vaginal secretions, breast milk, and saliva. Following the initial infection, there may be a transient viremia during dissemination of the virus. The virus is detectable in the blood at this stage, and the host may respond with clinical symptoms similar to any mild viral infection. During this time, the virus infects a variety of cells expressing CD4 molecules. During the progression to AIDS, the number of T cells lost is greater than the number of infected cells. This is most likely due to the combination of death of infected cells, death of uninfected cells, and the death of other infected immune cells. The loss of T cells is detectable as a fall in blood levels, so this is used clinically as an indicator of disease progression. Death of infected cells may be the consequence of lysis of infected cells after producing new viral particles, but it may also be the consequence of targeted killing by the immune system. On the other hand, uninfected cells may be chronically active in response to HIV itself or in response to infections common in individuals with AIDS, resulting in the death of these uninfected cells by apoptosis. It is also thought that other infected CD4 positive cells, such as dendritic cells and macrophages, may also die. The death of these cells probably results in the progressive alteration and destruction of lymphoid organs. 3 phases characterize the progression and clinical picture of HIV: the acute retroviral syndrome, the latent phase, and finally, clinical AIDS. The acute retroviral syndrome corresponds to the initial dissemination and transient viremia an infected individual might experience after HIV infection. As the infection spreads, humoral and cell-mediated immune responses are mounted against the virus. The mounted immune responses are indicated by the development of virus-specific CD8 positive cytotoxic T cells and also by seroconversion, which refers to the change from a seronegative to a seropositive condition with development of specific antiviral antibodies. These processes usually take place over 3 to 6 weeks after exposure, and the acute retroviral syndrome presents around the time that these processes are completed, so also around 3 to 6 weeks after infection. This clinical illness only lasts for a few days, and then it enters the latent phase. During the latent phase, progressive loss of CD4 positive T cells and destruction of lymphoid organs occurs. Few or no clinical manifestations are present until eventually, after a variable period, usually years, when the blood count of CD4 positive T cells has fallen below a critical value. At this point, where the loss of CD4 positive T cells is critical, the patient becomes susceptible to serious opportunistic infections, secondary neoplasms, or clinical neurologic disease. These diseases are referred to as AIDS indicator diseases, and once the patient has developed these diseases, the patient is diagnosed as having clinical AIDS. The clinical pathologic manifestations of AIDS are a consequence of the acquired immunodeficiency. Opportunistic infections may be from reactivation of latent infections or from other opportunistic pathogens. Organisms commonly associated with AIDS include intracellular microbes like viruses, the fungus Pneumocystis jirovecii, and atypical non-tuberculosis mycobacteria like the Mycobacterium avium complex and other organisms like Candida and Cryptococcus. In healthy individuals, these microorganisms would normally be addressed by T-cell mediated immunity. Affected individuals also become susceptible to virus-associated malignancies, for example, B-cell lymphomas caused by Epstein-Barr virus and Kaposi sarcoma caused by human herpes virus 8. Furthermore, some patients may develop neurological symptoms like dementia, which is thought to be caused by CNS infection as the result of macrophage or microglial infection. Early in the course of HIV infection, the administration of highly active antiretroviral therapy markedly reduces the frequency of development of opportunistic infections and secondary neoplasms. These antiretroviral drugs block different steps of the HIV life cycle, but do not completely eradicate HIV infection. Pre-exposure prophylaxis, also referred to as PrEP, is a newer prophylactic measure that uses the antiretroviral drugs to prevent contraction of HIV. PrEP is taken orally, and the recommended dosing schedule is daily. Unfortunately, AIDS is still a global issue, even though the understanding and management of HIV infection has improved significantly since the recognition of AIDS in the 1980s. According to the WHO, around 33 million deaths globally so far have been associated with HIV infection. An estimated 38 million people are currently living with HIV, and it is estimated that around 20 million people worldwide are currently accessing antiretroviral therapy. However, even with the advent of increasingly effective antiretroviral therapy, the infections continue to spread in parts of the world where these therapies are not widely available, and the prospect of a cure is still far away. With respect to the recent events, the past year has tragically disrupted HIV-related health services in areas like sub-Saharan Africa, although the impact of these disruptions is not yet clear. Nevertheless, the potentially devastating clinical impact of progression of the infection, combined with the possibility of unexpected global crises, complex logistical management, and other challenges, further highlights the necessity for a cure and eventual eradication of this disease. A considerable effort has been made to develop an effective vaccine, which will likely be necessary to control HIV worldwide. However, attempts until now have been unsuccessful due to technical challenges related to the immune response and the high degree of variation in subtypes of HIV, which is due to the surprisingly high mutation rate in GP120. As a result, current therapy for HIV and AIDS remains focused on prevention of infection, public health measures, and antiretroviral drugs. In a more positive light, as science continues to improve and new therapies are continuously developed, there is hope that there will one day be a cure. So with that, we've reached the end of this talk. Thank you again for tuning in. I hope that this lecture was clear and that it has helped your understanding of immunopathology. I'd love to hear what you think, so if you have any feedback or comments, please take a moment to fill out the feedback form. Alternatively, feel free to leave a comment or shoot me an email if you have any comments or questions. Thank you again, happy learning, and the best of luck.